Hi, my name is Dr. Robert Kaufman, and we're about to go beyond the Terminus. I was reviewing one of the videos that I recently posted on Beyond the Terminus about great-looking endo cases that seem to fail for no reason. I mentioned extraradicular infection as one of the possibilities of apparent failure. I realized that I neglected to discuss one other issue that causes apparent persistence of periapical radiolucent findings that initially appear to be of endodontic origin, but actually are not. They are misdiagnosed. Are you aware of the problem known as cemental tears, or probably more correctly called cemental delamination? At a recent American Academy of Endodontics meeting, there were several presentations regarding this topic, and it seemed that while the majority of endodontists knew about this fairly rare phenomenon, there was a lot of confusion as to the origins of the cemental tears and how to diagnose them and how to best treat such cases. What is a cemental tear? A cemental tear is a complete or incomplete separation along the cemento-dentinal interface, the type of root surface fracture typically seen in single-rooted teeth that may present itself as a periapical or periodontal radiolucent finding. Here's a clinical example of an extracted tooth. We can see that the cementum appears to have separated and flaked off of the dentin. I want to thank Dr. Gary Carr for this fantastic image and for the research that he does at the Perf Institute. In many cases, it may have been improperly diagnosed and referred for endodontic treatment. Most patients presenting with this problem are older than 60 years, and they're predominantly male. There's a history of parafunction and moderate to severe attrition. Unlike many other endodontically related problems, a history of trauma by itself is not generally a factor in these cases. They generally aren't traumatized. So how do we know whether the case is indeed a cemental tear, and how do we treat it? Many studies have shown that this is a relatively rare phenomenon with less than 1% prevalence. CBCT imaging is the essential tool in helping us determine the presence, extent, and position of the tear. Clinically, there's usually a deep unilateral periodontal pocket associated with this area of the tear. The tooth is generally percussion and palpation sensitive, and most often these teeth are responsive to pulp tests. They have normal pulps. But because these teeth are frequently misdiagnosed and accessed in error, this is sometimes difficult to determine because they may have already incorrectly had previous endodontic treatment. The localized periodontal area has gingival swelling or is associated with a draining sinus tract. Because cemental tears are frequently associated with the lateral surfaces of the single-rooted teeth, they're often confused with root fractures. There are a few differences between these two problems. Firstly, root fractures in the posterior teeth generally are mesiodistal in orientation. Anteriors and premolars generally tend to have fractures in the buccolingual area, especially in endo-treated teeth. The exception being maxillary premolars with mesiodistal cracks. Most importantly, these root fractures cannot be detected visually in the radiograph, usually. They are more likely to be discovered by the pattern of bone loss adjacent to the fractured root surface, whereas cemental tears show up as a thin radioopaque fragment along the root surface that's often visible in conventional and CBCT images. We see these best when we look at the axial view in a CBCT image. Again, special thanks to one of my mentors, Dr. Gary Carr, for these outstanding CBCT images. Clinicians have attempted to classify and stage cemental tears by position, extent of the radiolucent findings, or bone loss. Discussion of these classifications is way beyond the scope of this video, but if you're interested, you can look up the reference that I post at the end of this video. Examination of radiographs and scans shows a thin radioopaque area either at the apex or in the lateral portion of the root that appears to have flaked off or displaced from the root surface. Without removal of this affected cementum, the problem will persist. Successful treatment depends upon the location, the size, and accessibility, and the ability to remove the fragment. Other factors such as periodontal stability of the tooth and of adjacent teeth, post-surgical aesthetics, and feasibility of access to the fragment are important considerations. If the fragment is coronal and more easily accessible, we may attempt to curette this fragment non-surgically or raise a flap and try to remove it surgically. We need to determine the extent and the position of the fragment in order to determine whether it's reasonably accessible either non-surgically or surgically. CBCT imaging, again, is the essential tool for determining this information. Treatment options can include extraction of the tooth and removal of the fragment and then intentional replantation, hemisection of the associated root when the problem occurs in multiple rooted teeth, surgical treatment without apical surgery or no treatment if the symptoms are minor, or if the area is completely asymptomatic. Again, many other factors play an important role in determining how aggressively we are going to go about attempting to remove this fragment with the current periodontal condition of the tooth, aesthetic considerations in the anterior portion of the mouth, and the level of discomfort or function being some of the most important considerations. So the next time you're considering treatment on a tooth that apparently has a radiolucent finding at the apex and deep periodontal pockets with periodontal bone destruction, consider the possibility of a cemental delamination or a cemental tear. Albeit rare, make sure to do pulp tests. It's unlikely that a radiolucent finding of endodontic origin will be associated with a tooth with a positive pulp test, and these particular radiographic findings. The point I want to make is this. Simply regarding the radiolucent finding at the apex of a tooth as an immediate indication for endodontics can be a significant error in diagnosis. Unfortunately, these delaminated areas can occur in adjacent areas of the root even after the initial piece has been removed. Therefore, the prognosis, especially in cases where the periodontal condition of the patient is less than optimal, is guarded. As with any condition, we always examine the pros and cons of attempting surgical exploration of the area versus prosthetic replacement. Thanks for watching this edition of Beyond the Terminus. Remember, when we do the right thing, we both get better, clinicians and patients. Please don't forget to like and subscribe. It's unsponsored and it's free. Tell your colleagues. Suggestions for topics are always appreciated. Just type the suggestion in the comment box below the video. I look forward to seeing you again the next time that we go Beyond the Terminus. See you then.